Welcome to this orientation on the Medmont E300 Corneal Topographer. We're going to talk today about optimizing the topography capture, more specifically toward orthokeratology. This session will start with very fundamental information for new users, but we're going to move on to more advanced concepts for those practitioners with a lot of experience with Medmont and ways to improve efficiencies. My name is Randy Kojima. First, we must begin by getting an accurate, ideal topography. And here we can see on the left, fissure size is an issue, the eyelash shadows are a problem, the rings are distorting, we've got a huge tear film wedge at the bottom. So these are the kind of things we want to avoid. The image on the right shows a more optimized capture, where we're covering most of the cornea, the lids and lashes are out of the way, and we can call that a good initial image. One of the things that we have to be aware of is the quality of the tear film. And when you look at this video, you can see how the tear film appears to be distorting or breaking up when we reflect the rings off that surface. So having quality tear film reflection is critically important to the quality of your capture. Here we have two images where the one on the left shows good placido reflection. The rings look parallel and even. The trouble, of course, is the lids are in the way. The image on the right would, on cursory glance, appear okay, but if you look at the rings near the center, you'll see some distortion. Well, let's blow that up. And if we zoom in, you'll notice that multiple rings have begun to break. And it's the central 10 to 15 that are most important for determining the entire corneal topography. So be very critical of your central rings. Now, this study by Szczesna and Iskander showed us that when we have our blink, the tear film moves toward stabilization. Then there's this sweet spot where the tear film will be stable. Then the tear film begins to break up. So related to corneal topography, we don't want to capture immediately after the blink. We want to wait a split second until we see the tear film smooth over. Then we want to try to capture our image within that period of time when it's stable before it destabilizes. So what I do when I'm capturing topography is I'll wait that split second after the blink. I'll watch the placido to see if the tear film appears to be moving. Then I'll try to get my image within 4 seconds of the blink. If I can't, I'm going to ask the patient to blink again to make sure that I'm maintaining quality tear film reflection. Now here we see a video of the tear film reflection looking ideal, where all the rings are reflecting back in a parallel way. We're not seeing any obvious tear film breakup. Here we have a photokeratoscope image on the left of this capture. Notice the rings from center to periphery all appear parallel and even. The lids are out of the way. The eyelash shadows are minimized. This would be considered a very good capture, and that's generated this topography where you notice the color contours are stretching to all quadrants of the eye. We also can see each color contour appears smooth and well-rounded, and from center, the steepest we can read, to the periphery, the flattest we can read, the cornea flattens at this very smooth and gradual rate. And that's pretty typical of a normal, healthy eye. So we would expect to see these contours appearing to change very gradually. Now, the problem is we don't know if one single topography capture is accurate. We have moving patient. We're not able to be completely steady with the camera, and we have tear film constantly in flux. So the way to address that is to take multiple images. That way you can see if you have reproducible information. And here we can see all the topographies look the same, and when we go to design our lens, we can choose the one with the largest area of coverage that appears to be the smoothest topography. Now, how many maps do we take pre and post treatment? And the story is you want to take 4 before Ortho-K. You want multiple maps to design your initial lens from. If you have multiple readings, then you can again choose the best one to build your initial lens and attempt to achieve the highest first fit success. But post-treatment, you don't need as many. So after you've done the fit, 2 topographies may be all that's necessary to have the quality of images that you require to assess the outcome. So multiple images to begin, you don't need so many post-treatment. Now, in spite of our best intentions, at times we're going to struggle to push the coverage across the entire cornea. And this is very evident in the very deep set eye in patients with very small fissures. So in that case, how do we address that we don't completely understand the peripheral cornea? And the Medmont has this very unique feature that allows us to stretch the image capture all the way to the peripheral cornea and give us a better understanding of this eye shape. So we can use what's called the Composite Eye Feature, and that allows us to take an image on the visual axis down the center of the unit. Then we have the patient looking down. We push the placido to the top. Have the patient look up, pushing the placido reflection to the bottom. Having the patient look temporal, moving the placido to the nasal side. Having the patient look nasal, moving the placido to the temporal side. So now we have 5 images to convert to topography, stretching our understanding of the peripheral cornea all the way around 360 degrees. So this creates the larger composite eye view, giving us an incredibly large area of information, in this case 11.7, more than the diameter of any Ortho-K lens that we might fit. This composite eye feature is beneficial in many ways. Not only does it help us to understand the eye shape, but in terms of the rigid contact lens we're about to apply, we want to know the shape that we need for the alignment zone. We want to know the edge lift that will be required, the depth that goes all the way to the center. How high do we want our contact lens? So if we're able to image well past the diameter of our lens, we can construct Ortho-K lenses with a high level of confidence. So this composite eye feature, you go to your capture window, select composite eye, then that brings up this flower telling you you're going to take a central image, centering the instrument to the apex ring, get a 95% confidence or better, zoom in, make sure the rings look parallel and even, then click select. The software will then say, ask the patient to look up approximately 4 rings. Again, we'll center the instrument to the central placido reflection. We'll work to achieve a 95% confidence or better. Then we'll zoom in, ensure those central rings are reflecting parallel and even. Then the software will say, ask the patient to look down 4 rings. We'll do the same capture on that central ring, working to achieve a 95% confidence or better. Zooming in to ensure quality tear film reflection or any lack of tear film breakup. Then the software asks the patient to look 4 rings to the left. We'll center the unit again with that placido switched over farther toward the temporal side, working to achieve our 95%, zooming in, then clicking select if we're happy. Finally, we'll ask the patient to look right 4 rings. Again, we'll center the instrument with that placido decentered to the nasal side. Then once we're happy with our images, we'll click select. And the software will need to go through each one to ensure that a pupil is there. The pupil's used to merge them together to create the larger view, the composite view of the eye. Once you've affirmed that you have 5 pupils, it will convert that topography or those topographies into the composite eye capture. In this particular patient, we're able to get a 12.45 millimeter visible iris diameter, an incredibly large area of capture. So this is a very unique feature that's available in the Medmont that no other topographer can do to help you understand the broadest area of the cornea possible. Now, this composite feature is very valuable to any orthokeratologist because it helps you to design the initial lens based on data 360 degrees around, from edge to edge. What's the toricity we need? What's the depth we need? What's the edge lift we need? This can help us to achieve a high first fit success. And this type of mapping becomes important not just in Ortho-K, but in your corneal GPs, or multifocal GPs, or keratoconic lens fitting, and of course in our scleral lens fitting. So when you can achieve a composite capture, try to, because it will just give you more data. The Medmont Composite Eye Feature uses a very complex algorithm to bring multiple topographies together. And in order to do that, it needs to find the pupil. So if you have an incredibly dark iris patient where it's struggling to find that border between the very dense pixels of the pupil versus that dark iris and it's also very dense black pixels, the instrument may have a hard time finding the pupil. In this case, we see the instrument was able to find part of the pupil, but it's incomplete. And in this case, we have a distorted pupil. So the dark irises can be a struggle to get a good image, but the good news is that you can draw in the pupil so you can create the composite. And this is something you do under the annotation window and then select pupil, which allows you to define it. One of the other sensitivities of the composite map is it's looking for the ring position on eye. And if 4 rings isn't the right amount, there may be times you see the instrument stop and it's not able to pull an image up while you're in the capture mode. If that's the case, simply switch the patient to 3 rings, try 2 rings, fixation change. If that doesn't work, try 5 rings or 6 rings. So if the patient has a very odd angle alpha, if the temporally displaced fovea isn't as high as most patients or much higher than others, then you may have to change that fixation. So the composite map capture is slightly more sensitive than the single map capture, and that's to do the complex work it needs to merge those images together. Now, once you begin with the Medmont, you're going to want to use the composite capture window. It's going to teach you. It's going to walk you through how you take those various images, how you take those various fixations, and merge them together. And it does that automatically. Now, once you become experienced and know what to do and what to look for, you might switch over to using a single topography capture and do your composites manually. And that's how I take my corneal topographies using the Medmont. I've understood what the composite wizard needs. Now I just use the single topography capture window. And this is a recommendation that you might use in practice. This is something we use at Pacific University. We take 2 images on the visual axis, 2 on the geometric axis, and 1 in each of the 4 principal directions. And we'll explain why. First, we want a few visual axis captures. That's with the patient looking right down the axis of the instrument. You'll notice the placido tends to be decentered, slightly nasal. This helps us understand the powers through the line of sight, the pupil in relationship to the line of sight, and what powers are distributed where. But we're also going to do a couple images on the geometric axis. So that's fixating the patient so the rings are centered to the iris, to the cornea, rather than along the line of sight. So now you have an understanding of the vision through the line of sight, and you have an understanding of where the contact lens may center based on the geometric topography capture. Now, how do you take those two different images? And the visual axis capture is super simple. You're just going to have the patient fixate right down the axis of the instrument looking at the center ring. So that one is the same as any other capture you might do. The geometric capture is used to center the placido slightly better. So we're going to have the patient look 1, 2, or 3 rings toward the nose until we see the placido reflection appearing to be centered to the visible iris. And that helps us to understand corneal displacement and where our rigid contact lens may want to center overnight. Then lastly, we're going to take those 4 different images in each of the principal directions to push the placido out to the far periphery of the cornea, 360 degrees around, and to help us get that larger eye view. All of those topographies will be converted to a colorized map, allowing us to image the entire cornea. So using this manual capture, it helps me to be more efficient, and it gives me a lot more information both pre and post treatment. So this is a suggestion that you might adopt in practice, where you have your 2 visual axis, 2 geometric, and 1 capture in each of the 4 principal directions. Now, how does this help you to be more efficient? Well, if one of these images couldn't register a pupil and I'm pressed for time, then I'll use the other 7 to build my composite. If I'm missing 2 or 3 pupils and I just don't have the time to draw them in, then I'll merge the other topographies that I have that show a pupil. Now, another benefit of doing this manually is if I really want that idealized composite capture and I've got a stack of patients lined up, I just don't have time to use the wizard at this moment. When you have your individual single captures, you can always go back to them at any point in time and draw that pupil in when you have the time to do it. So using the manual gives you a little more flexibility in how you and when you build that composite. Now, how do you do this manually generated composite eye capture? Well, you're going to highlight the 2 images on the visual axis, the 2 images on the geometric axis, and all your 4 in the principal directions. You highlight them by clicking and dragging, or hold down your control key and click on each one of them. Obviously, clicking, dragging, and releasing the mouse is the most efficient. Then we'll go up to analysis and composite eye, and then the software will automatically build our composite for us. So this will help you to be a little more efficient. And you can take any number of maps and turn them into a composite. You could take 2 topographies. You could take 20 topographies and turn them into a composite. So the more images, the better, because you're just adding more data points to average out and more information 360 degrees around. So using the composite when you can get it is going to help you to build that first lens and achieve that high first fit success that we all want. Now, could you build a Ortho-K lens without using a composite? And the answer is most definitely. You'll notice why Medmont is preferred as one of the optimal topographers for specialty contact lens. A single topography capture gives you the vast majority of the cornea. The small cone placido that Medmont uses is able to push the rings to the far peripheral cornea. We get a pretty large view of the cornea. Now, what are some of the things that we use to analyze pre-ortho-K? And of course, the corneal astigmatism. Here we have a 2.54 diopter corneal astigmat, a relatively high sill to begin ortho-K with. We can look at the flat K of 42.27, or about 42.25. We know this is a median cornea. Steeper corneas tend to respond better to ortho-K. Flatter corneas tend to respond poorer to ortho-K. Or at least high RX changes are much tougher in your flatter corneas. We can look at the eccentricity. The higher the E value, the better the potential for ortho-K effect. The lower the E value, the more challenging it will be to achieve a high RX change. We look at the pupil area, and obviously bigger pupils in orthokeratology are better. We're able to push more minus, more aberrations toward the retina to slow down eye growth. We can look at the visible iris diameter and say this is a very median 11.7 cornea, so a normal diameter of ortho-K lens should work satisfactorily. Finally, we have the SAG differential, the sagittal differential at 8 millimeters. Now, what is that? That number tells you when it's recommended to use a toric ortho-K lens or a symmetric. At Pacific University, we use a threshold of 30 microns. If the SAG differential is 30 or greater, we're going to use a toric ortho-K lens. When it's under 30 microns, we're going to choose a symmetric ortho-K. Now, what is the SAG? And of course, what we're trying to determine is across an 8 millimeter diameter of the cornea, what is the height of the eye in microns between the flat meridian and the steep meridian? So if we take this eye, we measure the flat across an 8 millimeter chord. This patient has a height of 1,064 microns. Let's go to the steep meridian. We're 1,129. If we subtract the two from each other, the depth difference is 65 microns. Now that's a fairly toric central cornea at 2.5 diopters of corneal sill, but it's a very toric peripheral cornea because you see the limbus to limbus astigmatic shape, meaning central cornea is astigmatic, peripheral cornea is astigmatic. This would be suggestive that we need a toric ortho-K lens. Now, we can construct a lens from any single topography. If we have a good quality capture, then we're likely to have enough information because the single Medmont map gives us such a humongous area of the cornea. But if you can get that composite, you're just getting more data. You can move forward slightly more confidently. Now, from the contact lens software in the Medmont, we're able to drop numerous different ortho-K lenses on that topography. And here we see on that same patient with 2.5 diopters of corneal astigmatism, our lens across the flat meridian. Notice across this axis line, we see our landing at 3 o'clock and our landing at 9 o'clock. So that's here and here, creating good lateral stability and trapping in that fluid layer that we want to create the ortho-K effect. Then across the steep meridian on this very toric peripheral cornea with 65 microns of sagittal differential, we look at the alignment zone in the periphery, and heading south towards 6 o'clock, we're going to have 98 microns of clearance very near the end of the alignment zone, and heading north toward 12 o'clock, we see again 92 microns. Our lens is a mile off the cornea at 12 o'clock and 6 o'clock. This will hinder centration. It will hinder comfort. It will hinder the hydraulic force that we ideally want. If we switch over and design a toric lens in the Medmont software, now we have the same landing at 3 and 9 o'clock, but in the steep meridian, you'll notice your alignment zone in much closer apposition at 12 and 6, giving us a tiny fluid layer to promote good tear exchange with this lens, to decrease the movement, increase the centration, and improve the hydraulic force, so we get the epithelial response that we need. Now, the other benefit of using a composite for your baseline, and we only need it for the baseline map, we don't need it for any post-treatment visit, is you always have that good quality reference point to compare pre versus post. So from the beginning of time in Ortho-K treatment, we're going to assess that patient, comparing always the baseline to the post-treatment. So a year from now, 2 years from now, 5 years from now, we're comparing the current effect in relationship to the baseline effect. So that initial pre-fitting corneal topography is so important to you. Now here we have the axial subtractive map comparing pre versus post and giving us the difference. And we see a blue treatment zone well centered to the pupil in our axial subtraction. We can click our cursor right in the center and we have a 3.7 diopter RX change. So we don't have to do a refraction because the axial map will tell you how much you've changed the apical corneal power along the visual axis. We can look at this axis line to assess the powers distributed within the pupil, and that's this gray area you see here, most minus in the center, least minus in the periphery, indicating to us we're creating a good myopia controlling shape. We're pushing the plus into the pupil as much as possible. Let's switch over to the tangential subtractive map. And here we're not looking at vision. We're looking at shape changes. And we see from this red ring the area where the epithelium is pulled on by the tear reservoir of our lens. That ring indicates the centration in the closed eye environment. So we understand that our lens is fairly well centered. If anything, on this left eye, a little bit temporal, a little bit inferior, looking at where the ring is in relationship to the black pupil. So our axial and tangential tell us everything we need to know post-treatment, and having that good quality pre-Ortho-K topography, our good baseline map, important for all the assessment that we do moving forward. Now, if you didn't have a composite, does it really matter? If you had a patient that was very fidgety behind the instrument, if you had a patient with a very dark iris, and we're not able to get a really good composite capture, then can we build the lens from one single map? And the story is yes. The Tan and Cho study from the world-renowned Hong Kong Polytechnic showed us when you take a Medmont topography, use fitting software to build the lens, in this case the B-free, you can achieve a 95% first fit success. So this study did not use the composite capture. What they did was they took multiple images. They looked at all of those images together. They picked the best one. Then they built the lens from that ideal single map image. So if you need to, you can use a single topography capture with a high level of confidence. You don't have to have the composite. Whether you're using the composite or the single map image, multiple studies in corneal GPs for keratoconic patients, in scleral lenses, and in Ortho-K have all been studied using the Medmont to build these lenses and determine what kind of first fit success could be achieved. And you can work with your Medmont knowing very confidently that a single map or a composite is going to be very accurate in building your lens. So there's many options you can use to approach your initial Ortho-K lens construction. A single map is good enough. However, you want to take multiple images and choose the best single image. If you can get the composite, this simply gives us more information to build our lens. It gives us the highest confidence in constructing the lens. But again, any one of our options is going to work, provided that we have good placido reflection. The final thought I want to leave you with is, how do we create efficiencies with this composite capture? We discussed how it's important to use the composite wizard when you begin to help you understand how to do it. But once you understand what Medmont needs to build a composite, then use that manual capture, that single map capture. Take as many images as you feel it's possible. The more images, the better. In our case at Pacific, we use the 2 on the visual axis, the 2 on the geometric, and 1 in each of the 4 directions. Now, if one of those images doesn't register a pupil, then we just simply would throw it out and build our composite manually from the others. If we were rushed for time when we were taking our captures, if we've taken single map images, we can always go back to them on our lunch break, or back to them at the end of the day, or back to them another time when we've got a window of opportunity to draw in the pupil manually. Or if we just don't have the time, we'll take all the images that we do have that register the pupil and build our lens from those. Or if we simply can't make out the pupil because we've got an incredibly dark iris patient, then we use the best topography that we have. Now, regarding the dark irises and the times when the instrument is struggling to make out the pupil, what can you do to help the instrument find that pupil border? And one of the very simple things that you can do is be slow and steady with your movements as you're taking the topography. If the instrument is moving around, then the patient focus is changing and the pupil is going to be much more dynamic. So if you're much slower and steadier with the instrument, the pupil will be quieter and it'll be easier for the Medmont to pick up that pupil border. Another consideration is room lighting. If you've got a very bright room, there may be a lot of light getting into the cone, and that might hinder the ability to pick up that border. So there's multiple ways that we can improve upon our ability to build a composite and be as efficient as possible. I hope this session will be helpful to you in optimizing your pre-Ortho-K captures and your post-Ortho-K captures, and give you the highest first fit success possible. If you have any questions about some of the things we've discussed, please reach out to your Medmont distributor and have them provide some more information on this topic. Thank you so much.